Good morning. Great. For the guys online, hopefully you guys can hear as well. So some of you may be aware that we have a big meeting in town right now. This is the problem with Miami. We have a lot of stuff in town. And IMAST is here right now at the Intercontinental Hotel. It's one of the biggest meetings of the year in spine. It's part of the SRS, which is Scoliosis Research Society. And because of that, we were lucky enough to grab Shay Best before he kicks off his day at the national meeting. I have trouble introducing Shay because he breaks so many molds, and maybe just for mostly the residents, I can bring up two particular issues that I think is particularly important that you need to pay attention to. The first is that Shay Best is the founder of the Issg, and when I first met him, we were at Johnson & Johnson headquarters, and I argued with him about about how we should do spine research and how it should be funded, and it turned out that he was right and I was wrong. Shay's Issg group, which is a team effort, but he really leads it, is responsible for the bulk of the literature out there now in spinal deformity. It's upwards of 1,000 abstracts and papers now published by way of example at NAS, which has nothing to do with Issg, maybe even against it. 27 podium papers are going to be from the Issg group. So that gives you some idea of the magnitude of the power. And the really interesting feature of this is because I know that everybody sitting here right now is struggling in their own mind to figure out, am I going to be private or academic? And this is a very neurosurgical thing. Now, Shay, you're a private practice orthopedic surgeon, so to speak?
Yeah, kind of. So
kind
I'm
of.
an HCA employee, so probably furthest as possible from being private practice, but we'll go with it.
But you're not
I'm
at university.
university.
Okay. But yet Shay, as whether you go by bibliometric measures or actual contributions and changes to how we do surgery today, ranks in the top dozen of people in importance in the spine world in this past century. So this is really not trivial. If you think about what I'm telling you, all of the models by which you're viewing your future career have been broken pretty much only by Shay Best, okay? And then the second feature, which I think is highly interesting, which is now becoming apparent to me, which is that spine surgeons are acutely aware of the biases and politicization by which our government chooses to fund medical research. That's been a sticking point for neurosurgeons that do spine for the last 50 years. But Shay broke that mold too. So on these two fronts alone, he has completely broken the concepts by which we view the future world, whether it be in your future career for research or your future career in terms of contribution. So Shay, tell us about how you started this. Thank you for coming here and getting up early for giving a talk.
Mike, it was beautiful. Thank you so much. That's really nice introduction. So Mike is a superstar and a good friend. So it's an absolute pleasure of being here. So kind of a long title here, but the thing I wanted to talk about really about the impact of the Issg and what we've done at this point now to improve the evaluation as well as treatment of adult spine deformity via multi-center research. So here are my disclosures, the majority of which that Mike was alluding to. That stick, oh, there it is. Are right in this the research support section, and I'll get into that here shortly. So if you look at the formula really for high impact research, and I think that you guys have gotten a lot of this probably through what you've done either in your research year or looking things up. If historically, right, it's come from a single center, right? One big surgeon, one or two big departments, right? Twin Cities and WashU, probably more lately for spine. And then at least on the ortho side, shock trauma and Harborview. And what did they have? They had one or two real dominant guys able to put together some concepts then regarding treatment that was relatively novel. But then what we've seen, I think, more lately is this emergence then of multi-center study groups, the harm study group and the PED side and the spine deformity study group, which was funded by Medtronic. Looking at adults and kids, and then more lately with the International Spine Study Group. And what this does, I think, for research clearly, is it creates not only a large collaborative membership through volume that you're not going to get in one single center, but the cornerstone to what you can do through multi-center research, through people who are truly engaged, is you create this concept of collaborative intelligence. And as you work together more and more, you get this machine learning where you're able to synergistically work together. And so, as Mike was saying, the concepts of academic medicine, at least from a research standpoint now, I think that it in this modern time have really been turned on its head. Because if you compare a single center versus multi-center research, the single center at this point, you can have one or two offs publications, but they can't keep up, right? Can't keep up in the number of cases, but it's more than a case thing, it's a collaborator thing, right? They can't keep up with the diversity of cases, not just volume, but a variety of cases, right? But it's more than the cases that are putting in. Again, it's this concept of collaborators and ideas. And then the other piece also about through our private entity, right, we're able to bypass much of the red tape and bureaucracy that you get through a single entity. And so we're able to be nimble, very much like a business then. And then because it's our own private foundation, we have ownership of the group and the data. So we completely regulate them ourselves. And so what I'll talk about today, I'll give an overview of the structure and organization of the Issg, and then have some impact or input on the productivity and impact of what we've done, and then talk about some specific studies that pertain to what our fundamental mission is then within the Issg. And then I'll reflect then on what it has and how it has impacted my individual practice. So here's our mission statement. We're a private independent foundation dedicated to perform the highest quality research to improve the evaluation and treatment of adult spine deformity and cervical spine deformities. So we're an independent private foundation that we formed in 2010. So what does that mean? We're our own four-wall entity that controls all revenue that comes in, that controls all membership, and that controls all productivity that then comes out. That is fundamental to what we do. The other piece that's fundamental to what we do is we engage only in prospective observational multicenter studies. So what does prospective study mean? These are a priori hypotheses that we generate prior to submitting IRBs. What does that do for us? That means that all the evidence that's generated from our research are either level 2, which is prognostic, or level 3, therapeutic. So the research that comes out from our high volume, high number of centers, high number of cases is actually equivalent to a poorly done RCT, right? And you know from your kind of research 101, right, that an RCT, if not done well, it's not going to be a level 1 evidence, it's going to be a level 2. And that is what comes out of the Issg. So how do we do this? We do this with standardized data capture, both using written and electronic CRFs. CRFs are clinical research forms, right? And so we obtain demographic, operative, and PROM and complications. And then we upload all of those data to our own database that we keep on a cloud. So everything is transferred then electronically. We then upload all the radiographs onto the cloud as well. And then for every patient that we have within our database structure, we have raw DICOM images from every pre and post-op visit for every single patient. We have 4 full-time employees that allow for real-time central QA of all of our data, and we do weekly queries on all site data. Again, centralized radiographic measures, so the sites aren't measuring the films. They upload to a cloud, and then they're downloaded to a central site, and then all radiographic measures are put into the database, and then we have centroids that are placed on all the radiographs, which then allow for downstream further evaluation of all the radiographs, which is done then real time. Every site must have a study coordinator, otherwise they're asked to leave, because we believe that we cannot keep up with the data that we have, and you can't have data quality. And if you have poor data quality, you can't be in the Issg. We have an executive committee, of which I'm the president, and then we have accountants and legal that oversee that we employ to help maintain our foundation. So we're 28 sites. Who are we? Right, 28 sites, as well as 2 in Canada. Everybody's like, well, why you the International Spine Study Group if you only US? So we'll put the I being Canada. As you can see, Mike Wang, we're delighted that he is part of our group. He is an absolute superstar and a gentleman. We've got 40 surgeons and scientists, and then we also collaborate through the European Spine Study Group, which emulated our foundation and is based in Barcelona. And then we also have very tight ties to Japan, which is going to be very important. And I'll show some studies in terms of why that is a strategic mission for us. So what does it look like for us from a working standpoint? We meet 5 times a year. There are dedicated ISG meetings in the fall, winter, and the spring. And then we have meetings at IMAST, which is now, as well as in the SRS. There's a point to this that's very important that, again, is fundamental to who we are. The attendees and the members of the ISSG are responsible for all of their individual airfare, lodging, and food, which we believe is critical. So why is that, right? It's not only critical because we run the budget and I run the finances for the entire foundation, right? But it gives an ownership of the effort. In this world that we live in, money talks, right? And we want absolutely no entitlement within our ISSG. So if you're going to come in and you're going to pay for your own airfare, you're going to pay for your own food, and you're going to pay for your own hotel, you're there because you are absolutely committed. We have a weekly administrative meeting that I run through our employees through the ISSG. And then we have pre and post abstracts submission to go through what we've done. And the workload for 2021, for example, we had about 107 ISSG Zoom calls. So roughly one, it's every 3 days, there's going to be some kind of ISSG effort that then is going on. We also maintain individual productivity metrics for group retention. We run this as a business, and just like any other business happens, there's going to be some hires and there's going to be some fires. And so I think that through our successful business, we need to maintain adequate productivity, which is why we have this structure. We have a labor division, which I think has worked very nicely. And so then how do we allocate work with all of this data? And what we do, and I think as you guys have seen this through your own department, you have these different divisions that run effectively. And so what we've done is, actually I'll do it here. We've split out then the different sections, benchmarking, the CADS study, which I'll talk about in a second, cervical, complex complications, and you can see the group leaders and adjacent to it. For example, myself and Larry Lanke run the CAD study. Manish Gupta runs a complex study. Eric Kleinberg causes complications. And Praveen Mumanimi runs MIS. Question is, what does this do for us? It provides structure and organization in terms of how we then look to then produce our research then going forward. But also, as you know, as you are handed over some form of responsibilities, then it develops work synergies and relationships and gives yet further ownership in terms of the mission that we have through the ISSG. Here are the studies that we have done since our inception. We started very, very early in 2007, carrying through March of 2022. We've enrolled about 4,200 patients, a little bit more, 4,257. Again, this is a tremendous amount of data, and then with the associated films adjacent then to the patients. And so here's what an initial inclusion criteria, which is a CRF, that we have for the CAD study, which is complex adult spine deformity study. The way we formed this study was based on this previous study that you see right here that has about 2,000, a little over 2,000 patients. We did a multi-level regression analysis of the patients from that study that had the highest risk for length of stay and complications. And we found that those were the most interesting patients from an economic standpoint, as well as sustainability for healthcare environment. And we wanted to evaluate those patients. And then we formed these 3 criteria. There's a radiographic criteria, right? But beyond just spine deformity, which clearly has integrated radiographic criteria, there's also going to be procedural criteria for these patients, right? And so there's going to be some deformities, but they don't have to be these massive deformities. And so if we had this repository of these kind of exotic deformities, it doesn't speak to the masses, right? And so we wanted to have research that's then transferable to what everybody's doing. And so as a consequence, then we have a procedural criteria, as well as this frailty or physiology criteria. And what does that mean? I think that we all know that there's some patients that are 80 going on 18. There's some patients that are 18 going on 80, right? And so we need to be able to suss through the patient's physiology to see if they can actually withstand then these procedures. And then for this study, the PON study had about 2,500 data points per patient. The CAD study has about 5,000 data points per patient. And what we've done then is based on the CRFs, we've then built out then our database, which as you all know through your research time, we formed discrete data fields, which then are populated then through the cloud for all of our patients, including demographic and socioeconomic, radiographic, implant procedures, biologics, and PROMs, as well as what we integrated this year, importantly, I believe, to be functional frailty and serology studies, which we'll then use downstream for our patients' evaluation. And then going forward, what we're going to do, or I should say what we have done, we have a cervical study and then an MIS study, and then all of these studies then work off of this same base platform. What does that do for us? One, it facilitates information exchange, right? Because we're all on the same platform and the researchers then don't have to acclimate to new CRFs. The other piece that then does, especially then, it allows for effective comparison across studies. So as we map then discrete data fields to compare pathology, say thoracolumbar to cervical, we're able to compare directly and seamlessly between the two studies. Here's what the CRFs look like, very in depth and detailed. For example, here's the posterior spinal fusion. First looking then at the, if it's done MIS, and if robotics are used and NAV is used, and then going down, we look at the volume and the type of the biologics, and then we look more in depth at the type and the location of all the implants, which is this page here. Looking at the interbodies, what's done on all patients from an interbody standpoint, what's placed, what biologics are done. And then this next one here, this one on the right here is the osteotomy page, calculating as well as tracking which osteotomy is done, then at what level, and then we have PROM for frailty and as well as functional assessments. You can see on the upper left-hand side, these are the legacy PROMs that we capture on all the patients, and then we've integrated the PROMIS CAT for all the patients, which, as you know, I'm sure NIH has mandated that if you are going to get a clinical grant from federal funds, you must integrate PROMIS in some form or fashion. We have a relationship through the Issg with Richard Gershon and Nan Rothrock, who actually created and sat on the chair for the NIH for PROMIS. And so through them, we've integrated the PROMIS CAT into then all of our studies. The CAT is computer adaptive testing, which reduces the ceiling and floor effects then for all of our studies. And then on the right, you can see the two frailty scales that we're indicating, and then an example of the hand dynamometer, which you say here, which again becomes more of a functional than measure for patient frailty. And then finally, obtain economic data via itemized direct costs then for all patients, so that we can translate our data purely not just clinical, but then how it applies then to the economics portions of it. So here is our total enrollment, for example. We're getting now in terms of how we actually track metrics, because we run this foundation very much like a business, and you can see the performance going down the list. There's Larry and myself and Chris Shaffrey, what they projected, and then what they have enrolled to date, and we hold everybody to what their metrics are. Larry projected high and he's catching up. I projected low. I've gone a little over. Chris has got some catching up to do, so I'll nag and bitch at him at the meeting today. And then here's what we get on a monthly basis. Namely, this is the site performance then on all of their metrics from a data standpoint. And what we do with this then is we say, not only what did you project, which is right here, but then what you've created. And then this then looks at the real-time QA that we have on all of our data. And this green category, which you see right here, that is a critical category. So the big thing that we insist on through our group is data completeness and data accuracy. And so that we track the amount of usable data that then goes in. Because if somebody submits a CRF and has enrolled patients and only half the data fields that are populated, and about a third of them don't make any sense because they're more than 2.5 standard deves of what the norm should be, that is not usable data for our foundation, and we cannot have that. So then we track these data then going along, and then each site gets a report card probably every other month in terms of how they're actually performing. Correct. Way off. Right. So what the sites, I think, especially as they're first coming into CADS and this, it's a very, very labor intensive study. And so they haven't completed all of their data, or it's still in the QA process. And so that speaks to twofold. One, if early on you're enrolling a bunch of patients, but you don't have good data, we then stop you from enrolling until you then actually catch up. And if you don't catch up, you're asked to leave the group. Then if at the 2-year process, you've done the same thing, we tell you to stop enrolling, get those patients back in. And if you can't get the patients back in, then you're asked to leave the group. Simple. Correct. It's data quality or it's follow-up issues. So it's both. And so I think that if the patient comes back in, but you have inaccurate data or incomplete data, it does nothing for our research. That still counts as a whole, because if you look at then our ends, the ends aren't going to match up for each discrete data category. So exactly. So UCSF just catching up right now. So they've been put on hold. At least one of the people there, Chris Ames, is falling a little bit behind. Praveen's done a good job getting the data in. So the question then comes of why all that? Why then comply with the torture? Why comply with the demands, right? The meeting schedule, 5 meetings per year, 107 Zoom calls. Why should you incur the cost? Like, why do this bullshit? Like, why would you do this? Airfare, hotel, food, time away from work and family, which is money and time and heartache. Why should you tolerate the constant scrutiny, data quality, right? The other piece about this, which I think it's very important to mention, is that for all the abstracts that come out through the group, we have a 2-step internal review process. Namely, the group leader and the section leader is asked to review all abstracts that then come out. And then we as an executive committee then also do a secondary review. And I'd say about 1/3 of all abstracts that are produced internally within the Issg are then rejected, and we don't allow them to be submitted because we want the highest quality research to come out from our group. So we don't, despite the volume that we have coming out, we don't put out a bunch of crap. I think it's research that we all believe in. So why should we put up with all that? It's simple. If you can comply with all this, you'll have unparalleled research productivity. So here's our productivity to date. At this point now, we're averaging about probably 70 abstracts per year, which in all reality, we're probably generating between 100 and 120 per year, but the vast, then about 1/3 of those then are withheld. And it's interesting, if you look at this truly then as a business model, this is us ramping up from 2009 to 2012, slowly getting data then into our database. And then this explosion then right here, that's where we hit number 1, 2-year follow-up, right? And that's where the cases are really coming in. But then beyond that, that's where we are working well together. That's where we believe in each other. That's where we believe in the mission. And that's this combined collaborative machine learning intelligence that I was alluding to. So where do we stand in that? We probably put out roughly about, like I said, it's 60 to 70 per year. We had best paper last year at the SRS, and for the 4th time, we had best paper at NAS. As Mike was saying, we cut down our, this is a bit of a COVID piece here, but we cut down our submissions to NAS this year. Despite that, I would say probably 2/3 of anything that said spine deformity and NAS, for example, came from the Issg. So it is all over the podium. If you look at the number accepted by year-end conference, as Mike was saying, roughly over 1,000 abstracts presented since our inception. We average about 35 to 40 publications per year. And this is interesting. If you look at where we're cited right now, we're cited about 2,000 times per year. And then if you guys sure know all this, the H index. If you look at us, it's a measure of productivity as well as impact. I mean, you can put out a bunch of slop, but if nobody's referencing it, then you're not really moving the needle, right? And so if you look at our H index for the past 13 years, it's about 55. And so here's a reference value. And so at about 60 to 70 after 20 years is considered a Nobel laureate. So we are going to easily blow past that number. So if you look at our productivity and the impact that we have, I think undeniably more productive than the vast majority of all departments that exist in the United States. So taking that, right, beyond the productivity, right, beyond our structure, then how does this pertain then to the actual research that we do? And how do we actually act on what our mission statement is? So if we then look at the traditional teaching for scoliosis, right? And if you look at a thing which all of you, when you go into practice, you're going to become definitely aware of, is called the Milliman criteria, which is how the insurance companies approve cases. The traditional teaching really in scoliosis and adult spinal deformity is that it's not painful. You get that all the time from the insurance companies, from pediatricians and the urologists that you'll talk to on the phone to get your cases approved. And where did this come from? This came from two studies from Stu Weinstein, one in JAMA in 2003 and one in JBJS in 2000, in which he looked at untreated AIS patients that then transfer then into adulthood and compared them into controls. So we took this repository of untreated idiopaths from Iowa and then looked at them as a transfer then into adulthood and compared them to controls. And what he found is he called them late onset idiopathic scoliosis, but this is really untreated adult idiopathic scoliosis, right? They had more pain in cosmetic versus controls. But in conclusion, he found that about 68% of the patients had little or moderate pain, which is similar to the controls, and found they had no function on marital status or no effect on function of marital status. And so the conclusion for those two papers, if you read that, it says right here, he concludes that it's essential that the community and the physicians and the public recognize that late onset idiopathic scoliosis is likely to cause little physical impairment other than back pain and cosmetic concerns. So how has that been translated? It's that adult spinal deformity, it's not really painful. And then treatment then as a consequence, probably unnecessary. And that's where you keep getting, especially in the Milliman criteria, this 50-degree piece. And patients aren't in pain and they probably don't need this. But there's some problems then with those studies, right? Number one, those studies did not then obtain standardized HRQOLs or PROMs, right? They use these modified pain scales. And those studies most likely would not have even been accepted to publication today. The other piece also, there's no accounting for the heterogeneity within adult spinal deformity for any of those studies. They looked only or primarily at thoracic scoliosis, but importantly, they did not evaluate the lateral plane. So I actually called Stu and said, can we reevaluate then this cohort and look at the laterals, look at the sagittals of the patients? He said, well, we didn't capture those at those times. Two major holes. And I think your teaching now, you guys are cognizant in it as much as a frontal plane, it's a sagittal plane that then causes pain and disability for these patients. So then the question then comes is, how do we have to solve, or how can we solve this misinformation problem, right? It's clearly a problem that's going to affect at least my field and your field. Well, we need to quantify the disease impact of ASD, right? And so then we took on this and published this paper in 2016, wanting to demonstrate the disability associated with adult spinal deformity. So we took an initial cohort of ours within the Issg for patients that had adult spinal deformity that had no prior surgery, about 500 patients, not a big number, but not a small number, right? But much more than they had in the Weinstein studies. And then we took their SF36, PCS, and the MCS, that's the physical and mental component scores, and then compared them to population norms within the US, compared them to generational norms, and then also compared them to chronic diseases. So what did we find? And we found that the red here is the ASD population, the blue is the quote normative population in the US. We find that the ASD patients for every age generation are functioning below the 25th percentile from a PCS standpoint, from a physical component score standpoint, and they have a greater decline in physical function compared to the normative cohort with normal aging from generation to generation. So you could say, well, all the ASD patients are, they're sick, right? So that has to account for it. So then we took ASD patients with no comorbidities and found the exact same thing, below the 25th percentile and greater slope of worsening over time from generation to generation. And then we compared these then to chronic diseases, and then we found it had a greater impact than or to say similar impact as cancer, as well as diabetes and heart disease. What does that mean? I think beyond, the impact that it has on health, right? It speaks to what Mike was alluding to at the very beginning, which he graciously introduced me. Much of the federal funding that we see now is going toward cancer, diabetes, and heart disease. And a fraction of it is going to spine deformity research. But what we're demonstrating here, it's a real call for federal funding, then, is that it has a tremendous impact, ASD does, on these other buckets that are similar, that get the vast majority of federal funding. But clearly there's a problem with those data, right? And so we know that adult spine deformity is heterogeneous, right? You can have sagittal or coronal and mixed deformities, right? You can have a curve in the thoracic spine and the lumbar spine, and there's a varying severity of the curves and the deformities. And so you say, well, what really is ASD? And how can you say that I got some patients that come in that are asymptomatic and some patients that are doing miserable? And so we said, all right, what we probably need to do is then divide those cohorts then into different deformity types, and then look at then the associated impact it has on their PCS values. And what we found is that the PCS worsens by the curve location, thoracic versus lumbar spine. And it also worsens according to sagittal malalignment. And I think we know this already, right? Worsening sagittal alignment, worsening PCS. Worsening scoliosis, worsening PCS. But then we took those data and then compared them for each deformity cohort and compared them to 2 other chronic diseases. And so this is where it actually gets very interesting. So here, this white here is the US general population. And this is summation in 3 bars. That's kind of research, right? You could work for 10 years and have 3 bars for all of your research. And so this is a comparison of adult spine deformity to cancer and diabetes. Similar. This three bars here probably summates 20 years of Stu Weinstein studies, right? This is the adult idiopathy then with thoracic scoliosis, similar then to the patient with chronic back pain. And this is where Weinstein made those conclusions. But then what happens if we look at patients with a lumbar scoliosis, namely a degenerative lumbar scoliosis? These patients are functioning to a patient with severe OA or heart disease. If we then take the sagittal alignment then into account, if you have a relatively small deformity in the sagittal plane, these patients are functioning similar to an RA patient who is functioning below the 25th percentile. If you are severely deformed, your SVA is greater than 10, you're functioning worse than somebody who is blind. If you take somebody who has a lumbar scoliosis and a severe sagittal deformity, these patients are functioning worse than an amputee. What does that tell us, right? Wide range of then disability by a heterogeneous then disease state, which ranges from relatively asymptomatic, right, from what Stu was saying, all the way to somebody who's functioning, who's blind or an amputee. So can have a massive impact then on function. So then what do we do with those data? Is what we do in the operating room then helpful for these patients? So the question then comes is, how do you counsel your patients when they ask you, how much am I going to improve if you do surgery on me? What is going to improve? Namely, what aspects of my life are going to improve? And then, quote, you get this all the time, am I going to be normal again? Patients ask that all the time. Well, how do you know that? You just pull some answer out of the hat? I mean, where does it come from? So we published this in 2020 and hypothesized that if baseline disability is dependent upon the type and severity of the ASD, which we showed from all those slides, a lot of talking on my part, well, then we hypothesized then surgical outcomes are probably also then going to vary based upon the type and severity. So the purpose of this study then was to look at the PROM domains most impacted by ASD, but most importantly, by the ASD type. And as we then look and assess patients, I think we need to evaluate different aspects of their health domains to assess then what aspects of their life are impacted. We also wanted to quantify the improvement after 2 years in each of those discrete healthcare domains, and then truly assess if patients are able to return to generational norm after 2 years, namely, will they be normal again? And so this is what we get for all ASD patients, right? This is the improvement after then 2 years, right? And so we see roughly about a 45% improvement in back and leg pain. If patients are told your pain is going to be all gone and you're never going to have pain again, that's bullshit. Not going to happen. But you can help them. You can cut their pain roughly in half. But the big aspect of it is look at self-image. Look at the gains patients get in self-image. That's also where we can impact these patients, and that also drives satisfaction with healthcare. Social function improves by about 33%, and physical function improves by about 30%, and mental health by about 25%. So this is, I think, the real telling tale in terms of what ASD is doing to patients, and this is for all comers, right? And this is how they deviate from the generational norm. So we take the normative population, form discrete health variables then within the population, and then see how it's impacted. Look at, this is self-image, social function, mental health, bodily pain, physical function. Very discrete functional health domain buckets, right? Look at the massive impact. Blue is preoperative impact, deviation from norm. 93, 94% of patients with ASD are outside the norm for more than one standard dev for self-image. Massively impact. What is that telling us? One, if you're going to assess adult spinal deformity via some kind of PROM, you need to assess self-image, but also see that bodily pain and physical function are then massively impacted. The other piece also, are patients going to return to normal? Will you be normal again, quote, after the surgery? And this says, well, if this was a yes, this red bar, this is 2-year post-op, would be back up to there. So no, you're not going to be normal, probably, right? But if the glass is half full, about half of those patients were normal. They reported the exact same self-image as then patients that had no deformity. But what we're doing in spine now, you're not really making it normal, right? You're taking a crooked spine that's painful and you're making it stiff, right? Straighter, probably less painful, but maybe not normal. And so we see that then in physical function, right? Pretty good improvement from pre to post for physical function, but again, probably not normal. But then what happens if we divide it into different deformity types? And if we take the thoracic ASD patients, you can see very good impact on self-image and back pain. But this is where it gets interesting, I think. If you look at the impact that thoracic scoliosis has on adult patients, huge impact on self-image, and 2/3 of patients then return to normal. This is helpful from a counseling standpoint. But look what happens to physical function. What that says is, this is deviation from norm pre-op, this is deviation from norm post-op. No change in physical function. So if the thoracic adult scoliosis patient comes in your office and says, well, I have a tremendous problem with pain and self-image, can you impact that? These data say yes. If they come in and say, I have no pain and not really concerned what I look like, but I want to improve my physical function, based on this data, you would say, well, probably shouldn't do the surgery because you're going to have no delta and you're going to be unhappy. If we look at lumbar scoliosis, very different than thoracic scoliosis, we see impact on self-image, but now lumbar scoliosis, this patient comes in the office, this is a pain pathology for these patients. And you can see the offset from norm. Clearly, you're going to see this resounding theme, self-image, but bodily pain and physical function tremendously impacted then in lumbar scoliosis. Double scoliosis behaved very similar to thoracic scoliosis. Huge impact on self-image, probably less so in pain, but it can be impacted. Sagittal plane, you guys know this already. The sagittal plane hugely impacted not only in self-image, but pain. But I don't think we typically think of sagittal patients as being then a self-image pathology, right? We know they're in pain, which this demonstrates to us, but this reiterates the concept of self-image and the importance of evaluating self-image in these patients. And finally, the mixed patient, which was probably the most common that we see, it's going to be a combination of the two. Again, impact self-image as well as pain, as well as physical function. And so I think that the ability then to use these proms, and what did our data tell us this, is that we can impact the disease. We can then help improve counseling for these patients. But there again are discrete differences in how these patients present, but also then how we can help impact then their disease. If we look then at patient satisfaction, this is going beyond just these physical metrics that are somewhat objective, and we say, well, what's your satisfaction? We found that we published in 2021, this past year, that the things that correlate most with satisfaction is the reduction, number one, in disability, but then number two, then improvement of the deformity based upon the deformity type you have. What does that mean? We took the patients that had low satisfaction, they had a very high residual ODI, whereas the high satisfaction group had then a low ODI, right? ODI is reversed. The low ODI is good, high ODI is better. And so it had an inverse relationship then with ODI. But we found that from a correlation standpoint that in the sagittal group, SVA correction correlated most with satisfaction, whereas in the coronal group, CSVL, you guys know these numbers all, and scoliosis correction correlated most with satisfaction. So disability, but then correcting the plane for which then they present correlates most with satisfaction. And so this is the piece that I thought was interesting then. If we take the Issg data and then apply it then to a Japan cohort, this gets us out of this kind of myopic, egocentric perception that I think that we have in the United States, looking then at healthcare. And we looked at matched patients from Japan versus the US and looked at surgery satisfaction. What we found is that at 2 years post-operative, similar alignment complications, and then similar improvements in the SRS-22R and the ODI, right? So reduction in disability, but a much lower satisfaction in Japan. And the correlates within Japan from a satisfaction standpoint correlated most with the pelvic parameters. What does that tell us? Within Japan, there's a tremendous amount of floor sitting that happens within the culture. And as a consequence, if you fuse these patients to the pelvis, and this gets to what I was talking about previously, it's very difficult for them to bend and sit on the floor and integrate fully then into the culture. And so I think that what we need to account for then with what we're doing for our treatment, because when we fix these patients in alignment, either you have to revise that patient or that patient is going to die with that alignment. It's one of the two, right? So if you're going to get it, damn well get it right the first time. And we know then for these patients, then especially in Japan, it's very, very different. And I think that we need to take into account these different cultural needs for not only pain reduction, but also function. All right, I will then, we've got about 10 minutes left. 10 minutes. I'll look Mike's saying ish. I'll look then at beyond what we've done from a research standpoint on a big scale, right? And then focus down in terms of how this has impacted my practice. So we'll look at a couple cases, then we'll be done. 71-year-old female, kind of has this dinky lumbar scoliosis with back and leg pain. So here's my workflow based upon what I know and what I've learned through this group and how it's influenced me. I'll get a full body EOS image on every patient, and I measure all the coronal parameters, namely all the scoliosis, and measure all the sagittal parameters, which you can see here on these patients. And these numbers are going to be important here very shortly, as are the proms, right? So she has a little bit of scoliosis, not too big, was about 42 degrees in the lumbar spine. And then her SVA is off about 76, PI minus LL, that's a fair amount off, right? So she's malaligned from the lumbar spine to her pelvis. And despite her pelvic tilt being 33, which is a little bit high, her SVA is still a little bit high at 76. And what does she say from pain standpoint? Well, back and leg pain about 7, 8 out of 10. Her ODI is about 48, which is a threshold then clearly then for disability. And if you look at her PROMIS scores, physical function is about 39. We know that the mean for that should be about 50. So she's low on that as well. So what do I measure in all patients that come in? I get a full body EOS, and every patient that comes in, my practice is probably 80% revision spine and deformity. And then I measure the coronal and sagittal planes on every single patient myself. I think it's a good academic exercise for me, and allows me then to discern what exactly is going on these patients. And then beyond that, it gives me an insight in terms of pain for these patients. These patients are not coming to your office for surgery. They're coming to your office to figure out why they're in pain and why they are miserable. And I believe that then getting objective measures, as well as measuring these radiographs myself, allows me to tell this patient why you're unhappy. And so patients hurt because they're malaligned, but they really hurt because they're trying to compensate through and because of their malalignment. And it's the compensation that causes pain for these patients. So let's break down these numbers you can see here on the right that I just went through. These numbers over here. What's happening? So she's got a PI minus LL mismatch, right? So PI minus L is 42. This age should probably be about 10 to 15. What do we know about lumbar lordosis? We know in isolation, it means absolutely nothing. There is no normative lumbar lordosis. But it's a critical relationship to the pelvis that then allows us for upright structure or upright posture. And so as a consequence then, the pelvis then is going to compensate for what the lumbar spine then is doing. And the way you compensate then is through pelvic tilt, right? And so if the lumbar lordosis is off from your pelvic morphology, pelvic incidence, right? You have to compensate then initially through your pelvis to stand upright. And what value is that? That's pelvic tilt, right? And we know that should be roughly about 20. So we see her PIL is off. We see her PT or pelvic tilt's off, which kind of goes along with what we've been saying. What else is happening? Well, she has interscapular pain. And so a lot of these patients will wind up getting a thoracic MRI scan, and it has absolutely nothing to do with their thoracic pain. The thoracic pain is occurring because she's compensating. So her TK or thoracic kyphosis is 11. Look how flat her thoracic spine is. Why is that? It's because she has this thoracolumbar kyphosis, and her pelvic tilt isn't allowing her to stand upright, so she extends her back. And that's why she's in pain. She's in pain because she's like this, she flexes her hips and extends her back. That's a classic posture for a spine deformity patient, right? And that's why they get thigh pain and back pain. And despite all that, her SVA is still high. And so she has a decompensated sagittal malalignment. She's compensating, but she can't get there. That's why she's miserable. So what are these reference values? We know through the Issg that if you get a pelvic tilt remember we said 10 and we said 20 and we said 50 for the values, right? Pelvic tilt, 20, ODI was 40 for all the comers that we found in this evaluation, looking at correlates between alignment and disability. We see that SVA greater than 45, those patients had an ODI greater than 40. And then we saw PI minus LL, right, 11, ODI greater than 40. So the values match up to an established benchmark threshold then for disability. So another question is, why then should you measure this alignment? Number one, assess their disability, but then number two, right, plan for surgery. Does undercorrection matter is the first piece. The answer is yes. If you pin those patients into a malaligned position, that's the patient who wakes up from surgery and they say, I was worse after surgery than I was when I came in. Because what you've done then is when you fix them into a malaligned position, you've taken somewhat of a flexible deformity and you turn it into a rigid deformity. And you've taken away all of their compensatory measures. So that's the patient that is miserable. We found that the patients then from the Issg, about a third were overcorrected, a third were under, and then about a third were matched. And we found that the patients that were undercorrected were absolutely miserable. But overcorrection also matters. So you got to get it right. So if you overcorrect these patients, right, they get junctional failure. And there are unsustainable alignments for these patients then. And so what we need to do is find values then to then match these patients for realistic measures in terms of what their alignment should be, which is where we came up with this concept of age-adjusted alignment. And looking at population norms, we then found that as patients age, they become progressively more sagittally forward. I wouldn't say malaligned, but they become sagittally more forward, because we know that the alignment of an 18-year-old should not be the alignment of an 80-year-old. And we found then, if you then take a patient and you overcorrect that patient, that's what leads to junctional failure, because they cannot maintain that alignment. And we found that with increasing correction and overshoot in terms of age-adjusted alignment, there was an association with an increasing angle of proximal junctional kyphosis and failure. We then looked at the efficacy of using just age-adjusted alignment values versus implant prophylaxis to prevent junctional failure. What does that mean? It means that you're going to go into surgery and you're just going to slap in a hook or a tether or cement at the top and hope it stops PJF. And we compared that to patients who then had no prophylaxis and were poorly aligned. So what we found is that 20% of patients that had no prophylaxis and were overcorrected had junctional failure. This isn't benign kyphosis. This is catastrophic failure. And so what does that mean? And so you say, well, I'm an experienced surgeon and I've been doing this for a long time and I was well trained. I don't need to plan and I get the alignment every time every right. That's BS. What this data shows us, about 1 in 4 patients is going to have a catastrophic failure if you don't plan for junctional failure. We found that implant prophylaxis helped, right? It reduced either a tether, a hook, or cement. It reduced the PJF rate down to about 13 to 10%. But we found alignment was just as effective as implant prophylaxis. And if you combine the two together and actually planned out your surgery and anticipated this event happening, it was even more effective, less than 10% a junctional failure. We then came up with then a scoring platform for these patients, and we found through this piece that was called the SAAS, we published this in 2021, patients that were undercorrected, less PJF, right? But poor HRQOLs. They didn't fail, but they had crappy outcomes. Patients that were overcorrected, more PJF, which supports what we just said. And if you're actually able to get it right, only about 21% of our patients in the Issg, which is sobering, less PJF and better HRQOLs. And then we also found then, based on this publication in 2021, it's not only an absolute alignment piece, but it's actually a shape piece. So the piece that we're working on now is finding an ideal shape for the patient, as opposed to just specific parameters. What does this have implications for? Clearly has implications for patient-specific implants, which I believe the field is going undeniably. We can't just go in the OR, bend the rod, put it in, and hope for a good outcome. Those days should be over. So then what I do then for all my patients, I assess then deformity flexibility, which I believe then allows me to then plan for the surgery. And here's what it looks like on that patient I showed at the very beginning, right? I'll measure my preoperative alignment, assess deformity flexibility, and then I'll generate my surgical plan. And this is the actual plan I have for my patient. I said, don't correct the fractional curve because I'll put her head over here. And then I set out my goals then for alignment. I then check what I'm doing sagittally in all my patients with a full cassette radiograph. And then I'll use a T-bar then to evaluate coronal alignment in the patients, because we saw in those previous images that if you fix their CSVL off to the left or the right, they're also miserable. And so here's our outcome. And this is where it gets interesting, I think, on these patients then. I think that if you look at her pre and post, again, it wasn't a very big deformity to begin with, but what happens on her is you can see that we get some correction in the frontal as well as the sagittal plane. But then what happened? Look at her pelvic tilt, goes from 33 down to 18. Just by correcting her sagittal plane deformity, she goes from this to that. And then what happens then in her thoracic kyphosis, it goes from 11 degrees, then it goes up to 28 degrees. You can see very flat spine, and this concept that we coined, reciprocal change, right? She relaxes. So the research works, right? It makes sense. What we're proposing, I think, is accurate. I'll do one more case and I'll let the basic science go through. Mike wants to get me off the stage here. So here is what we look like from an actual alignment stamp from an age, which I think was pretty good. And then this last case is a 41-year-old female who had this remote fusion from T4 to L4 in 93. And it's a bigger deformity. You can see unable to stand upright, has back and leg pain for about 10 out of 10, unable to walk for about 2 blocks for about 10 years. So what is this patient's problem, right? She's malaligned in the coronal and the sagittal plane. And what is she doing to try to stand upright? She's compensating, right? You can see flexing her knees, retroverting her pelvis, hyperextending what remainder she has here, and hyperextending her neck to try to stand upright. That is what's making her absolutely miserable. And so if I measure these parameters on her, right? So her pelvic tilt is 46, her PI minus LL is 37. Despite all that, her SVA is 210. You should all know these values at this point by now, right? So she flexes her knees to try to stand upright, hyperextends her pelvis, and she still can't get there, right? And so I get a flexibility film of the patient and I see, actually she comes down pretty well in the coronal as well as the sagittal plane. And so I think this puts together then an ability for me to plan out this surgery that, despite being relatively big, it's fairly flexible, right? And so my thoughts are on this patient, given the flexibility, probably don't need a 3-column osteotomy. I can probably get everything from the front to pull her over and then pull her back in the frontal plane as well. And you can see here preoperatively and postoperatively, you can see good alignment then in the coronal plane as well as the sagittal plane. But the big thing I think this is showing us is look what happens to her compensatory measures just by correcting the sagittal coronal plane. The pelvic tilt comes way down, the knee flexion goes away, and she doesn't have to create this functional then deformity and leg length discrepancy to pull herself over. So clearly then, I think what we're preaching to the Issg works. So conclusion, what have we learned? I think this is probably the true secret of the Issg has been a ton of wine over the past 13 years, which has been great. But beyond that, I think through the advances we've had through technology, data capture, and then working together, there's some tremendous limitations to single site research. There's nothing wrong with it, but it's just limited where we are right now, bandwidth, brain power, and bureaucracy standpoint. The critical components, I think, to our success has been friendships, mutual respect, but importantly, this collaborative intelligence and machine learning together. And I think where we stand in the future is going to be in predictive analytics, data capture, and then more patient-specific metrics. Thanks, guys. I don't know. No questions? Yeah. That's an awesome question. And I think that what we have been using, I think, is kind of age from a chronology standpoint. And we know it's probably inaccurate, right? Because there's some patients who are 40 going on 80, and some patients who are 80 going on 40. And so how do you pick the right age procedure and try to match it to it? And we should probably be evaluating what their physiology is, right? That's where frailty comes in. But I think it's a spectrum from resiliency to frailty, and that's what you're alluding to a younger age versus older age, versus somebody who's resilient, can recover, versus somebody who's older, who's more frail and more susceptible. And that's the piece I think that's coming to it. But we know then, well, according to age, and hopefully from this resiliency frailty spectrum, we'll be able to tailor make then the surgeries for those patients. Great question.
Some people cannot hear the questions. Please use the microphone. Let me get one to you.
I was going to ask, for all your patients preoperatively, do you have them, when you check for flexibility, in addition to flexion extension, do you always get the coronal x-ray, lateral x-rays checking for?
Yeah, so eliminating gravity. And so the flexes, I think, are tough, right? And so what I'll do is get a full body standing EOS image stereoradiographic from front and back, and then I'll get a supine AP and then a bolster lateral AP. If they're absolutely miserable, you can use the MRI and the CT scan to get the sagittal alignment, but they put them in the scanner and they put pillows between their knees and they give them margarita and they're get comfortable, you know what I mean? And so this really truly gives a sense then of what the flexibility is. Supine AP and bolster lateral. Good question. Cool. Thanks so much. Appreciate it.
Okay, so have a real treat for everyone today, and glad to see everybody face to face. Good morning. So the researchers in my project look at spinal cord injury, traumatic brain injury, stroke, and more neurodegenerative diseases such as Alzheimer's and Parkinson and MS and now ALS. So anyway, today I have a privilege of introducing Dr. Roberta Brambilla. Roberta is associate professor in the Department of Neurological Surgery, and she's been working on spinal cord injury and demyelinating problems such as MS. So today she's going to tell us about this really interesting topic about, do inflammatory oligodendrocytes contribute to the MS pathogenesis? Roberta, thanks.
Good morning, everybody. Thank you, Dr. Dietrich. So I am going to see how I can operate this thing. Okay, this is the one that goes. How do I go back? Okay. Sorry, I'm just gonna.
You can use the cursor on the keyboard, left and right. That's the easiest way.
Okay, perfect. I just wanted to use maybe the mouse here to. Can you see them? Yes, perfect. Okay. All right. So as Dr. Dietrich was explaining already, I've been working on mechanisms of neuroinflammation and neuroimmune interactions in the context of neurological diseases for quite some time. So today I'm just going to go over some of the data that we have, some of the studies that we have done in the last couple of years looking at the role of oligodendrocytes and specifically the inflammatory function of oligodendrocyte in the context of demyelination. So I'm going to talk about a little bit about the pathophysiology of multiple sclerosis, which is one of the neurological diseases that I study the most. I am going to hopefully convince you that there is evidence to suggest that intrinsic oligodendrocyte dysfunction can underlie or can potentially contribute to primary progressive multiple sclerosis pathology. And I also want to discuss some of the data that we have indicating that one of the signaling pathways that regulates this inflammatory potential of oligodendrocyte is TNF signaling through TNF receptor 2. So what is multiple sclerosis? Essentially, it's a demyelinating disorder of the central nervous system. It is the most common neurological disorder in young adults. And it is associated with a variety of risk factors. There is no clear cause, but we know that there's a number of risk factors that highly contribute to the establishment of MS. And these include single nucleotide polymorphism in some genes, particularly immune-related genes. For example, also vitamin D deficiency has been associated with MS risks and viral exposure. For example, Epstein-Barr virus has been associated with risk of developing MS. Essentially, here we have demyelination that occurs in the central nervous system, and it can happen within the brain, but also within the spinal cord. So there are various MS phenotypes. The most common phenotype is the relapsing remitting form of multiple sclerosis, which presents at onset in about 85% of cases. And in this phenotype, we have the development of lesions and inflammatory episodes that are followed by periods of remissions that can be complete or incomplete. But this goes on over time with this alternation of periods of the neurological disability and recovery. Over time, this relapsing remitting form of MS can develop into a secondary progressive forms of MS in about 60% of cases, in which at a point, we won't see any more remissions after the periods of neurological dysfunction, but there is a constant and progressive neurological disability that accumulates with no recovery periods in between. And in about 15% of cases, there is a form of MS that presents, again, in about 15% of cases at onset, which is called primary progressive MS. And in this case, we have the development of a neurological disability and the progression of the neurological disability from onset with no remission and no recovery. So this is definitely the most aggressive form and fortunately also the rarest form of the disease. So what happens in MS? The pathophysiology is quite complex, but the most accepted view of the etiology of MS follows the so-called extrinsic hypothesis of MS, meaning in this case, it is an activation of the immune system, a T-cell mediated activation of the immune system that will lead to an acute inflammatory response. And that means that immune cells, T cells, but also myeloid cells and B cells will have the ability to cross the blood-brain barrier that typically is highly permeable in these situations. They enter the central nervous system, and here, either directly or indirectly through activation of local inflammatory glia, they can attack oligodendrocyte, causing oligodendrocyte cell death. Obviously, this will lead to demyelination, and the demyelination eventually will lead to axonal injury and neuronal loss. Now, axonal injury and neuronal loss are really the two causes, the two main culprit of the irreversible impairment that you eventually see in the CNS. So the primary progressive form of MS, and so this pathology that I just described is very well fitting with the relapsing remitting form of the disease. But the primary progressive form of the disease it is quite different in the sense that axonal damage, demyelination, and neurodegeneration have been shown to occur also in the absence of immune cells. So there are areas of the white matter in the CNS often completely devoid of immune cells, yet we have axonal degeneration and demyelination. So, sure, of course. Yeah. 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 Right. So we know a lot more than we used to, but it's actually correct. About 20 years ago, it was the first paper that was published that showed, that was Bruce Trapp work, that showed that there is axonal degeneration even when the myelin is there. So even in the absence of demyelination, the axons in people with MS are already damaged. So it's not axonal damage caused by the demyelination, but it's even independent of the demyelination. So that's one point. The second point is definitely demyelination can lead to axonal damage, and the mechanisms can be multiple. We know, for example, that axons that are damaged have a high have damage to the mitochondria. Mitochondrial dysfunction is something that occurs in axons that are demyelinated, but is also in axons that are not demyelinated yet damaged. So there's a lot of debate as to whether mitochondrial dysfunction could be the cause of the axonal damage and neuronal damage, or if it is secondary again to the demyelination. But certainly it's one of the mechanisms that is thought to be participating in this neurological damage, neuronal damage independent of demyelination. There's still a lot that we need to learn, but certainly the strategy here is to remyelinate, to protect the axon and to repair. So certainly this is where the field is going. Yeah, I hope I addressed the question. Okay, so going back to this form of disease, right? We do have axonal damage, as I just mentioned, and demyelination in the absence of immune presence in certain parts of the CNS. Obviously, it's not always the case, but this sort of led to the idea that perhaps we do have intrinsic neurological damage, again, that is primary. So that's why we are talking about intrinsic hypothesis of MS, where, again, events within the CNS itself are the trigger to the MS pathology, and the immune system activation is actually secondary or concomitant to the neurological damage that we consider to be primary in this case. So essentially, and this is sort of the hypothesis that we have been investigating in the lab. The question is fundamentally, what are then these intrinsic CNS processes that may underlie primary progressive MS pathogenesis? And specifically, which CNS cell population could participate in these processes that may trigger disease itself. Now, we do know that there is evidence that oligodendrocytes are dysfunctional, and there is heterogeneity in MS, in oligodendrocyte in MS. So a paper published about 20 years ago by Claudia Lucchinetti, where she classified and basically described very carefully the pathological characteristics of the multiple sclerosis lesions in the different areas of the brain and the spinal cord. She essentially, oops, where is that? Okay. She essentially observed that there were areas in which oligodendrocyte seemed to be dystrophic, and where they would, they seem to be damaged in the complete absence of immune cells, with the damage that was reminiscent of virus or toxin-induced demyelination rather than autoimmunity. And we know now from from recent studies with single nucleus RNA sequencing studies in postmortem human MS samples and control samples that in people with MS, oligodendrocyte and oligodendrocyte precursor cells are not passive targets, but are active immunomodulators in MS because they do show a variety of genes that are associated with immune functions that are highly dysregulated compared to people, to samples without MS, tissues without MS. So the question is, can these oligodendrocytes be themselves primary contributor to PPMS pathogenesis and not just the target of damage, but again, the contributors to the damage? So this is a question that we've asked in the lab, and we have done this using two methods together, two approaches together. One, we differentiated oligodendrocyte from human-induced pluripotent stem cells from PPMS and control individuals. And also we did immunohistochemistry on postmortem primary progressive MS and control white matter tissues. So this is a project that Melanie Plastini, a former graduate student in the lab, graduated just a few months ago, worked as part of her thesis project. So first, let's start by talking about oligodendrocytes that we differentiated from PPMS and control individuals. The question here we were asking is, are these oligodendrocytes in PPMS intrinsically different from control oligodendrocytes? So in order to do that, we differentiated human pluripotent stem cells from, again, PPMS and control individuals using an established protocol. This is just to show you how the differentiation goes. Basically, we have these neural stem cells that are, neural stem cells that are put in culture and differentiated for a long period of time at different steps along the differentiation process. These cells can start expressing unique markers of differentiation by day 12, for example. It's not moving. Oops, now it's moving too much. Okay, by day 12 of differentiation, the cells start to express OLIG2, which is marker of the oligodendrocyte lineage, suggesting that the cell have committed to that lineage. Then they are eventually differentiated into, along the process of differentiation, I cannot make this go. Okay. Along the process of differentiation, they become mature oligodendrocytes and expressed by day 55 of differentiation, this marker called O4. And then eventually by day 75 of differentiation, they reach their terminal differentiation and they start expressing more mature markers such as MBP, myelin basic protein. So this is what the cells look like at the end of the process of differentiation. These are the oligodendrocytes that we obtain. And here you see they co-express all these different markers of 4, MBP and OLIG2, suggesting or indicating that these are terminally differentiated oligodendrocytes. So what we did is we analyzed these cells in vitro. Obviously, we had to characterize this culture, and we found that, in fact, we can produce a high number of oligodendrocytes, about 40%, 45%, 46% of our cultures are OLIG2 positive oligodendrocytes. We do also obtain a high number of astrocytes actually through this process of differentiation, which is not unusual. And then we have a small percentage of new and positive neurons that we also obtain, and a variety of other cells that are sort of not being able to be identified. But the vast majority of the cells are, as we anticipated, oligodendrocytes. So these oligodendrocytes were quantified, and what we found is that of these OLIG2 population, the entire OLIG2 population that we obtained, the number of O4 positive cells, meaning the cells that have reached a more mature state of differentiation were reduced in the pluripotent stem cells, in the iPS cells that were derived from the PPMS individuals. So less, here they are quantified, less O4 positive cells within the OLIC2 population, suggesting that there was a reduction in the ability of these cells to actually mature towards a differentiated phenotype. We did not see differences in the number of MVP positive cells, which are the terminally differentiated cells that produce myelin, suggesting that the cells are slowed down in their process of differentiation, but once they get there, once they get to the O4 state, they can actually continue on and produce myelin normally. These cells are not only just few in numbers in the PPMS lines as compared to the control lines, they are also dystrophic. Here is a picture of a control oligodendrocyte, O4 positive oligodendrocyte, which is nicely ramified, as you can see here. But in the PPMS cells, in the PPMS oligodendrocyte, we have a clear reduction in the branching and in the size of the cells, suggesting that they are not normal looking, they're certainly dystrophic. And this is another picture to just show that and to quantify this reduced ramification and branching of these oligodendrocytes, this reduced complexity. So we definitely know that there's not only there's less of these O4 positive cells, but they're also not normal looking, again, less organized and harborized. So this indicated to us that there could be really a difference between these cells in individual with PPMS as opposed to in control individuals, and to try to better understand what the mechanisms, or rather the genes that could potentially differentiate these cells from the control cells, where we decided to do an RNA sequencing experiment where we isolated these O4 positive cells from our culture, uses flow cytometry by sorting these cells with FACS. We extracted the RNA from these cells, and then we sequenced the RNA. And this, again, is work that was led by Melanie, but Arita Desu, another graduate student in the lab, now graduated, also participated in this work. So what they found is that when we compared the transcriptome of these oligodendrocytes from PPMS individuals to the control oligodendrocyte, thousands of genes actually were differentially expressed. And this is just a volcano plot that shows the genes that are differentially expressed between the PPMS versus the control cells. A number of genes, hundreds of genes, are downregulated here on the left, and a number of genes are instead upregulated here on the right. So when we looked more carefully at the processes that were altered within this gene population, we found that, and these are gene ontology terms, we found that a variety of genes that were associated with cell adhesion and cell signaling were downregulated in the primary progressive MS cells, and a variety of genes that, for example, were associated with apoptosis were associated with the upregulated genes that were found in the PPMS cells versus the control cells. So again, a number of processes that are altered and suggest that these cells are certainly not similar to, or are certainly different from the cells that we obtain from control individuals. So to try and kind of narrow down this list of genes and start working on some of these genes and start to investigate some of these genes, we made a list of the top 20 upregulated genes, and this is the heat map of these top 20 upregulated genes in our PPMS cells compared to the controls, and this is the list. And there's a number of genes that are of interest. Some of the top upregulated genes here are actually mitochondrial genes and mitochondrial pseudogenes that we really don't know what they do, but there's a number of them. But there are certainly a number of genes that are immune related. I'm pointing at a couple here. NLRP2 is one of them, for example, highly upregulated. And many others are addition molecules. And again, I am pointing at a couple of here, addition molecules here. So that seems to suggest, again, that these oligodendrocytes have a dysregulation of immune processes, dysregulation of genes that are associated with immunity, but also maybe dysregulation of genes that are important for their ability to adhere. And adhesion is essential for the cells to be able to connect with the neurons and myelinate, obviously. So when we looked at the downregulated genes, again, we found in the PPMS oligodendrocytes immune-related genes that were downregulated. Here I'm pointing at a few of them, and adhesion proteins as well. Again, suggesting that these cells certainly do not behave as normal cells. So we decided once again to narrow down our list to a few genes of interest, and we focused our attention on NLRP2 that was upregulated in our PPMS cells by quite a lot. We confirmed the upregulation of this gene by qPCR. And why we were especially interested in NLRP2. What is NLRP2? NLRP2 is an inflammasome. And we know that inflammasome, because of recent studies, has been implicated in multiple sclerosis pathogenesis. In fact, this paper that was just published a couple of years ago indicated that NLRP3, which is another member of the inflammasome family, could be a prognostic factor and a therapeutic target for primary progressive MS. So that really is the reason why this NLRP2 gene got our attention. And also we ourselves in the lab, in collaboration with many of our colleagues here at the Miami Project, including Dr. Dietrich, Keen, Deriverovakari, and Bramlett, we had just completed a study a couple of years ago showing that blocking inflammasome activation in a model of MS actually improves the outcome. So definitely we were interested in pursuing the idea that inflammasome could be associated with this PPMS, dysfunction of oligodendrocyte in PPMS. So what is NLRP2? NLRP2 is a component of the NLR family of inflammasome. Essentially, NLRP2 combines with other proteins, with the ASC adapter and with procaspase-1 to generate these complexes, these inflammasome complexes. What that does is it leads to the activation of caspase-1. Caspase-1 will then activate, cleave pro-inflammatory cytokines such as pro-IL-1 beta and pro-IL-18 into IL-18 and IL-1 beta that are highly inflammatory and immunomodulatory. This is one of the many things that inflammasome activation will do. And NLRP2 is part of this family of inflammasome that lead to this process. And NLRP2 is a relatively new inflammasome that was only described in astrocyte up until this point, again, by our colleagues here, Dr. Deriverovakari and Keen. But in our case, we find it to be expressed in oligodendrocyte, which has never been described. So we did go to to confirm the expression of this NLRP2 in our cells. And there you see down there NLRP2 immunohistochemistry in green, where NLRP2 co-localizes with O4, which is the marker for our mature oligodendrocyte. And here you clearly see the co-localization of NLRP2 with O4. We do see expression of NLRP2 also in control oligodendrocyte, but this is minimal and not nearly as upregulated as in the PPMS cells. So obviously, what we wanted to know is NLRP2 expressed in the actual primary progressive MS tissue, in the human tissue. And so we did immunohistochemistry in sections of normal appearing white matter that we have from PPMS individual with PPMS and control individuals. This is a normal appearing white matter of the brain. And as you can see here, in these two panels here, NLRP2 in green is expressed, is co-localized with O4 expressing mature oligodendrocyte. There's a high co-localization of the two in the PPMS and high expression, but this is not observed in the control cells where, yes, there is some NLRP2 expression, but nearly not as upregulated in the O4 positive cells as in the PPMS individual. So suggesting that, again, it could be expressed in an aberrant way in PPMS and potentially implicated in pathology. So this is definitely one of the things that we are following up on in the lab. So just to summarize what I've shown so far, we know that in PPMS, oligodendrocytes have a reduced capacity to differentiate into O4 positive mature oligodendrocytes, suggesting that this could be that could lead to a potentially reduced repair capacity, which again is essential for repairing demyelinating lesions in the context of MS. We do know that these cells have an altered gene expression profile compared to normal cells. And many of the dysregulated genes are associated with immunoregulation, inflammation, and adhesion, to name a few. So one of the immunomodulatory genes that we are especially interested in pursuing is this NLRP2, because it has been implicated in inflammatory processes, and I didn't go into that, but also in cell death itself through pyroptosis. So basically, the model that we're working on is this. In normal conditions, we have oligodendrocytes that are typically, there to do their myelin function. They myelinate, they proliferate to produce enough cells to form new myelin, and their ability to produce immunomodulatory factor is relatively minimal. This is really not what they do normal in physiological condition. But if they are intrinsically dysfunctional, as we believe they may be in primary progressive MS, for example, they will have a reduced capacity to form myelin and to proliferate, but they will increase their ability to release inflammatory and immunomodulatory molecules. This is what we believe happens in the context of MS. So if there is a pathological trigger, we believe that this already dysfunctional, intrinsically dysfunctional oligodendrocyte will enhance even more their ability to produce inflammatory molecules and completely forget to myelinate and to proliferate. And this may be one of the mechanisms that may underlie the triggering of primary progressive multiple sclerosis. This is our working model. So the release of these immunomodulatory molecules by these altered oligodendrocyte will have the ability to go on and activate microglia and astroglia and propagate the damage, basically adding on to the already inflammatory capacity of astrocytes and microglia. So the question now is, what are the pathways and what are the signals that regulate this intrinsic immunomodulatory inflammatory capacity of oligodendrocytes? And that's another thing that we have been studying in the lab for quite some time. And we know now that this ability, this inflammatory and immunomodulatory capacity of oligodendrocyte is regulated, at least in part, by TNF receptor 2 signal, by one of the members of the TNF receptor family. And how do we know that? First of all, we have been studying TNF in MS for quite some time. We know that TNF, tumor necrosis factor, which is a cytokine, is implicated in MS pathology. TNF is synthesized as a transmembrane native protein, and it is in this form able to activate TNF receptor 2. It is also cleaved into a soluble form by the TNF alpha converting enzyme, or ADAM17, and in this soluble form, TNF will be able to activate this other receptor, TNF receptor 1. We know now that soluble TNF, TNFR1 signaling in neurological disease is mostly detrimental. And we know that instead, this pairing of membrane-bound TNF with TNF receptor 2 signaling is actually protective through the activation of cell survival pathways, anti-inflammatory pathways, and remyelination mechanisms. And so we have been especially interested in this latter mechanism, this latter signaling pathway, because we are interested in exploring this pathway and this receptor for potentially as a target for MS therapy. So where is TNF receptor 2 expressed in the central nervous system? We know that it is expressed in pretty much all glial cells. It is expressed on the oligodendrocytes and the oligodendrocyte precursor cells, but it is also expressed on microglia and in astrocytes. Obviously, we were especially interested in the oligodendrocytes. It is expressed in the oligodendrocytes, and we know that when we ablate this receptor from the oligodendrocyte lineage, we actually cause more damage. We cause worsening of the pathology in the EAE model of MS. So the EAE model of MS is the most widely utilized model of multiple sclerosis, which is an immune-induced model by which where we can induce locomotor dysfunction and clinical phenotype that resembles relapsing remitting chronic MS by injecting MOG peptide into the animal. So this MOG peptide will induce an immune reaction, which will lead to the development of neurological symptoms that can be scored on a clinical scoring system that goes from 0 to 6, with 0 being a normal mouse and 6 being complete, of course, death of the mouse. Now, the paralysis is typically observed within this range of 2 to 4. And the paralysis is rostral, is caudal to rostral, meaning it starts with loss of tail tone and tail flaccidity to go on to develop into hind and forelimb paralysis. So here you can see that when we ablated TNF receptor 2 from the oligodendrocytes, specifically using a transgenic mouse model here, we did observe a worsening of the clinical phenotype in this EAE model of MS, with these mice having a lot more paralysis and locomotor dysfunction as the control mice that are here indicated here. So what we know that is that especially there is a reduction, an exacerbation of the damage and of the disease phenotype in the early stages of diseases, where these mice reach much more rapidly a worse disease peak. So we were interested in understanding what could be the cause of these enhanced clinical phenotype early on in disease. So we started analyzing our mice and our tissues at the preclinical time point of 10 days post injection of MOG, when the mice yet do not develop yet symptoms. So what we see is that at this time point already, at 10 days post injection of MOG, we have an active microglia proliferation with an increased number of microglial cells that you can see here that are counted in the spinal cord of these mice. And these go on to be even more evident at 14 days post-induction of the disease. And this was associated with an increased permeability of the blood-brain barrier in the spinal cord, where extravasation of the Evans blue dye was measured more at a higher degree in these mice that did not have TNF receptor 2. And this led to the much more robust extravasation of immune cells from the periphery into the CNS, with these CD4 T cells, myeloid cells, and neutrophils, among them macrophages and neutrophils, being present in the spinal cord of these mice without TNF2 at much higher levels early on, again, in disease. So now really the question is, how does TNFR2 regulate this immunomodulatory function of the OPCs? That seem to definitely be the case based on our data in vivo. So to address that question, we decided to go with an in vitro approach. Again, Rita did these experiments. She cultured oligodendrocyte progenitor cells, precursor cells, from wild type and TNF receptor 2 knockout mice. and stimulated these cells with a cocktail of inflammatory cytokines. Here we have TNF, interferon gamma, and IL-1 beta, and these are cytokines that are found highly present, highly upregulated in the MS environment, in the CNS of people with MS. So she cultured the cells, stimulated the cells, and then did a gene expression analysis of these different conditions to find that the cells without TNF receptor 2 were highly different from the cells, from normal cells, wild type cells, after stimulation, with hundreds of genes that were differentially regulated, most of them upregulated, and a number of them also downregulated. These are all the comparisons that she made. I'm not going to go obviously through all this data. I just wanted to show you that among these differentially regulated genes, many of them, again, are associated with immune modulatory function. Here you can see these are all genes that are important for immune function, for antigen presentation. So these are MHC class 1 molecules that are highly upregulated in our TNF receptor 2 knockout OPCs after stimulation, and they are significantly different from their wild type counterpart. So a number of them, as you can see here, are upregulated, and the list goes on. But this is just to say, once again, that we have an increased inflammatory immunomodulatory function when TNFR2 is not there. And these are immunomodulatory cytokines and chemokines that are highly, again, upregulated in these cells, including interferon gamma, which is present in these cells, lacking TNFR2 almost in twice as much as in the control cells. So this is basically the model that we are, again, going back to the model that we were working on. Once again, physiological condition, myelin formation and proliferation is the main function of oligodendrocyte, minimal immunomodulatory function. But then in the absence of TNFR2, it's as if cells were undergoing a form of cell stress with their ability to produce immunomodulatory molecules a lot higher than in the case of normal oligodendrocyte, with this balance of functions that is completely skewed towards inflammation. So obviously in pathological condition, already oligodendrocyte are stimulated to produce more of these factors, but if TNFR2 is not there, this effect is even more robust. So clearly, this suggests to us that TNFR2 is a target for to be modulated to promote recovery in MS. Now, obviously, the ultimate experiment to really determine whether or not TNFR2 is therapeutic in MS would be to activate it right in the oligodendrocyte and to determine whether or not we can see a recovery in the AE model of MS, for example. So to do that, what we did is we generated a transgenic mouse. I'm going to go very quickly over this. We generated a transgenic mouse where we can actually overexpress TNF receptor 2, not knock it out, but overexpress it in our cell of interest. This is the construct that we use, TNF receptor 2 and a reporter, EGFP, are expressed in these transgenic mice dependent on the type of TTA transgene that we breed them with. Here, we obviously bred these mice with a TTA line that is driven by the PLP promoter, meaning the cells will express TNF receptor 2 exclusively in the PLP expressed in mature myelinating oligodendrocyte. So why we did that? Because obviously we wanted to see whether activating this receptor in vivo in the myelinating oligodendrocyte will protect from EA. Unfortunately, this is in fact the case. As you can see here, mice, this PLP TTA TRE TNFR2 mice with TNFR2 overexpression have a much lower disease phenotype as compared to the control mice. And this basically validates all our studies indicating that yes, TNFR2 is protective and activating TNFR2 actually can lead to a benefit in EAE. So this is sort of for us, the confirmation that we need to go after TNFR2 as a target for repair, which is what we're doing in collaboration with our colleagues at the University of Copenhagen that are developing these TNFR2 agonistic small molecules. And I had some other data of single cell RNA sequencing, but I'm just gonna stop here and just thank the people that have contributed to this work, mostly Arita, Melanie, Placido, and the student, current student in De La Morena and Brianna that really had contributed to this work. Thank you for listening.
Thank you very much, Roberta. That was outstanding. Any questions from the audience or people on Zoom? Please just unmute your mic and ask those questions, please. Well, of course, I thought the implications of inflammasome signaling, especially in in some of your later studies, is very intriguing. And this is the iPS cells that were generated are human iPS cells,
Yeah.
because you're looking at
Yeah,
MS patients.
yes,
So
definitely.
that's very encouraging.
Yeah. Yeah, so it's one of the things that we really are pursuing. We are thinking that certainly it could be involved in the pathology itself, but we are thinking that it could be even a biomarker of PPMS. So we're exploring the possibility that perhaps overexpression or presence of NLRP2 in the CSF of individuals with PPMS could be an indicator of disease phenotype or even progression. So we're working with some of our colleagues in Denmark to collect CSF samples from individual with PPMS and also individual with other forms of MS to test that possibility. Yeah.
You mentioned pyroptotic cell death. Have you seen direct evidence for pyroptotic cell death? Well,
In this-
pyroptotic cell death in human samples?
No, I have not. We haven't really looked at that yet, but it is a possibility if the Gasdermin pore is activated in response to this NLRP2 activation or other inflammasomes. This could lead to direct cell death of the oligodendrocyte, and then the release of cellular material could be also inflammatory and could lead to the triggering of CNS intrinsic inflammation as primary inflammatory, response rather than secondary response. So that's definitely one of the things.
Yeah, that would implicate the TNF cell death mechanisms that you were talking about that integrate. That's what I was
Certainly, yes.
Yeah, that sounds very well. So, now we've got some Gasdermin knockout mice. I don't want to make your life any complicated it is in terms, but you're very good at generating these transgenic mouse models. Now you could actually maybe integrate Gasdermin knockouts into your, and that seems to be a very powerful tool now in terms of differentiating between pyroptotic cell death and other types of inflammatory mediators. So
makes sense. Certainly something we can explore. Yeah.
Any other questions from the group on Zoom? Well, if not, Roberta, thank you very much for just an outstanding presentation. Thank you so much.
Thank you.
Have a great day.
You too.